Hi, everybody. Welcome to our talk today on substance use disorders in older adults. I am board certified in internal medicine and psychiatry, and I have spent my career working with older adults who have complex medical and behavioral health needs. So I have no disclosures to make. Our learning objectives for this brief talk are to list out key components for assessing older adults for substance use disorders, working to identify alcohol misuse and withdrawal in older adults and corresponding interventions, and note that there probably is the largest evidence base around alcohol compared to other substance use disorders. Identifying prescription, non-prescription, nicotine and caffeine misuse in older adults, and then being able to list interventions, both for alcohol use and other substance use disorders. And I really want to start this talk with some background that I cannot overemphasize the importance of. You know, the DSM-5 manual really moved us away from talking about substance abuse and substance dependence into looking at substance use disorders. And one of the biggest reasons for that was the problems around stigma. We do not call people who have type 2 diabetes sugar abusers. We don't criminalize people for abusing sugar when they have an insulin regulation disorder, as people with diabetes do. When you think about the word abuse or abusers, the things that most often come to mind is sexual abuse, child abuse, spousal abuse, and other crimes. And it really contributes greatly to the stigma around substance use disorders, this criminalization of their behavior and their illness. One of the other things that DSM took into account was that despite lots of education, it is very challenging to tell whether somebody has substance abuse or substance dependence. And there are particular definitions for those, but they are intertwined and used incorrectly pretty routinely. And so DSM-5 really removed both of those and came up with substance use disorders and combined elements of substance dependence and substance abuse from the older model. And really the goal here is to bring substance use disorders into the medical world, where we can treat them as the medical diseases that they are, and hopefully make some progress for people who are suffering with them. And if you want to look at like how common are these, so this is information for people age 65 and older by selected types of drugs. The percentages haven't really changed very much. There may be a slightly larger use of amphetamines and methamphetamines than there was back in 2011, but overall, these are pretty accurate. Looking at United States data for emergency department visits. And what you'll see is that pain relievers are the #1 category. And if you look at that, opiates or narcotics are the lion's share of the pain relievers that lead to ED visits. The next biggest category, and it's huge, is benzodiazepines. That's medicines like lorazepam and diazepam. And then we get into alcohol in combination with other drugs or alone, antidepressants or antipsychotics, cocaine, heroin, marijuana, and then the methamphetamines. So that's just to look at it. You know, what you'll see is prescription and non-prescription pain relievers and opiates, at least in the US, has just been an exploding medical emergency. But there are multiple other categories that have challenges. And when we're talking about substance use disorders and older adults, there really are two different categories. And it turns out that it's really helpful to, when you're doing an assessment, to figure out which group your patient or client falls in. So there's a group of people with young onset substance use disorders who developed their disorder prior to age 50, and it has just continued. Now, this is a pretty small subset because a lot of people either get into recovery of one sort or another from their substance use disorder when they're younger, or they don't make it to getting older than 50 because there can be some notable morbidity and mortality related to substance use disorders. And then the second set, which I think is larger, although we are still gathering data, is older onset substance use disorders. People who had a normal pattern of use prior to age 50, but something happened after age 50 and they developed abnormal use. And that almost always happened after an event. And there's a couple reasons to separate people into these two pathways. One is because treatment approach can differ, and the other is because of some of the other psychosocial factors just to take into account. But this is just one little study because I don't have time to go over all of the data with you. But what I want to tell you is there is hope. The thing about older adults who have substance use disorders is that it's a very different group of people than people who are young, who are currently having substance use disorder active problems. And one of the good news is that treatment compliance, the ability to participate in treatment, the willingness to participate in treatment overall, and the success with treatment is much higher for older adults compared to substance use disorders as a whole, which doesn't mean that, you know, person A or B will fit into one group or another, but it does, as a group, older adults are much more likely to respond to treatment and to engage in treatment. If you look at early onset versus late onset, what you'll find is that people in late onset, there's less family alcohol use disorder, and there's greater current psychological stability. So people with late onset substance use disorders are not coming from a place of having experienced long-standing psychosocial and psychological instability that can often happen when your substance use disorder is, you know, begins during your formative years. One of the very most important things I think, and that I do whenever I am treating people or assessing people for substance use, and I actually use the same paradigm for all substances, including nicotine, tobacco use disorders. And I also use it actually for people with diabetes and heart disease and neurological disease, is figuring out where someone is in the stage of change. You know, there's multiple different paradigms for looking at recovery from substance use disorders. This is a paradigm that I have found works for me when I'm working with patients. And so when I assess someone and I believe that they have a substance use disorder and I'm diagnosing them with that, the number one thing for me to make sure I get into my note is what stage is the person at? Is the person, do they realize that their substance use is causing them some problems? Or are they still at a spot where the substance use is the solution and not the problem? Because if somebody believes that using substances is the only thing that's going to help them, if the first thing you talk to them about is getting rid of the substance without working to help them have other ways to meet their needs, you're never going to get success. And so your interventions that you're going to recommend and use really depend on what stage a person is at. And so pre-contemplation, that's, you know, people are seeing the substance use as part of the solution and not as a part of a problem. contemplation, that's where a person is beginning to see that the substance use might be part of the problem, and they might need to think about changing some of their behaviors and some of their substance use, but they're very uncertain about it. So they're contemplating it. And so the primary therapeutic task there is really helping people get to a point that they choose change, not you recommending change for them. What you want to do is create the supportive environment so that they can choose change. The next stage is kind of the determination, getting committed to changing, considering how to change, what to change. And so that's the point where you want to really work on tangible things that people can do, and you want to look at change strategies. The next step is the action stage, where people are actually trying to change, where people are trying out different methods to decrease their substance use. And they're going to be in a spot where some days are going to be better than others. Most people are not going to be able to like quit cold turkey and just walk away. So your job as the healthcare provider working with them, your job is to help implement change strategies and looking to recognize risks for relapse and how to learn how to eliminate potential relapse. So again, the person with the substance use disorder really needs to do much of the changing. The next stage is the maintenance, where people have actually made notable changes in their substance use, and you want to help support them and encourage them and work on developing new ways to meet whatever need the substance use was meeting for that person in the past. You want to replace the substance use. And then recurrence. Substance use disorders like diabetes, like heart disease, like many other illnesses, it's a relapsing type disease. So it's very common to have relapses. That's a normal part of it. You don't want to kind of isolate a person. You want to encourage them, make sure that they know that sometimes that happens. And when it happens, let me know and we'll get to work on seeing what we can do to help support you. So when we look at older adults and substance use disorder treatment, there's a couple things that have been identified by the Substance Abuse and Mental Health Services Administration here in the United States, SAMHSA. So these are key features that they recommend for substance use disorder treatment in older adults. One is that treatment be age specific, and age specific support also involves making sure that other people in any sort of support group are of a similar age. Having a support group where one person is in their 80s and everybody else is between 15 and 25, that's going to be very difficult for that older adult to communicate with and recognize the exact same types of support. So you really need age-specific support. You need to know about what developmental stage people are at, and older adults are definitely, at a different developmental stage than younger adults. A key to all substance use treatment is non-confrontational. There was a time where confrontation was built into treatment programs and people thought, that was the way it had to be. But research has shown us that non-confrontational environments tend to work better. And there's nowhere that that's more true than with older adults. As with all substance use disorder treatment, you want to build or rebuild self-efficacy. People don't get to be 65 or 75 or 85 without having done many things in their life and accomplished many things and survived many things. So helping older adults call on all the things that they have used successfully in the past is how you're going to be able to help them succeed through this challenge. And occupational therapy, OT, is a particular discipline that is very helpful with older adults as a whole. not everybody recognizes occupational therapy's importance. And so I always like to include mention of that. Occupational therapists, one of their key things is helping assess functional cognition and helping figure out how to support somebody's functional cognition so that they can meet their goals. And so that is a very key discipline. They can help a person recognize what they can do well, what they're having challenges with. And you want to go with what they're doing well. What are their strengths, right? That's how they're going to be able to improve things going forward. Specific for older adults, just like younger adults have various stage of life considerations, with older adults, loneliness, loss of loved ones, loss of employment, moving, so losing entire networks of people, as well as sort of your orientation you're in geography every time you move. So older adults just have a whole different series of stage of life considerations, and you need to keep all of that in mind and be informed about that when you're working with older adults. You want to establish a recovery-oriented social support network. And again, it's really important to make sure that the components of that have knowledge about older adults. And then you want age-appropriate pace and content. So when you're, if you're using examples of success stories, you don't want all of your success stories to be people who were 25. That's going to be hard to relate to for older adults. Older adults are who do not have cognitive impairment are as able to learn as anyone, but they do need a little bit more time to process information. So their thought processes tend to be slightly slower, and they need a little bit more repetition than younger adults. So you need age-appropriate training materials, and you need people who are running classes or support groups need to understand some of the differences around how older adults' brains are working. Older adults are the most resilient people on the planet and have great strengths, especially in their verbal skills compared to younger adults, but there are things where you do need to modify your plan. So, and I went over this before, older persons commonly misuse substances. And when we look at this, just a couple key things. Where do medications come in this? As a physician, medications are something that I commonly prescribe for many conditions. And specifically for substance use disorders, alcohol use disorders do have some medications that can be used to treat them. Nicotine disorders have medications that can be very helpful for that. Opiate use disorders have some medications that can be helpful and used to treat those folks. But at the current time, stimulants and marijuana and caffeine treatment, really, there aren't a lot of medications that show good evidence. And there's a lot more evidence for psychosocial or psychoeducational interventions for those substance use disorders. And so one of the key things when you're assessing someone is what substance use disorder do they have? What substances are they, misusing? And then how can I help direct them into treatment? And so as far as prescribing medications, at the current time, we only have a few specific substance use disorders where medications are indicated. Just a couple words about alcohol use disorder. And one of the reasons is just this tends to be one of the most common. And at least in the US, it's a little bit more socially acceptable to talk about it now than it used to be. It's still very hard to talk about substance use disorders because of stigma for most substances. But alcohol seems to be, people are, perhaps because it's so commonly used. The alcohol use disorder prevalence is, 1 in 10 or 15 and 100 older adults or so have alcohol use disorder. And symptoms include erratic changes in affect, mood, behaviors, malnutrition if a person has had alcohol use disorder, ongoing. Bowel and bladder incontinence can be seen. If it's been going on a long time, you can see gait disturbance. You can see reoccurring falls and injuries. One of the interesting facts that I found is if somebody has had their alcohol use disorder for more than 3 years, then it's going to be a little bit more challenging to treat. If a person's alcohol use disorder has been going on less than 3 years, often short interventions work. And so again, that's one of those reasons why, is this an early onset or a late onset, is so important to know. Can I do a brief intervention and have great impact, or is this somebody who's going to need a more intense intervention? And 1/3 of older adults begin their alcohol use disorder or other substance use disorder after bereavement, loss of a spouse or other family member, retirement, loneliness, or after a major illness. And, sort of what's the common theme here? If we were all live together, I could get people to call out the answer, but the common theme that I see is loss. And that is sort of the developmental stage that older adults have, coming to terms with and learning how to navigate loss. That is one of the most profound developmental tasks of late life. Other symptoms: anxiety, nervousness, blackouts, confusion, weight loss, falls. Falls especially is something that might lead to a presentation in a medical setting. So it's something you always want to look at there. Intoxication, sometimes it's really, really obvious, and that's what you can see. That's what these signs are. Other times it's less obvious. Which brings me to one point. What about screening tools? There are a lot of screening tools out there. Unfortunately, most screening tools have not been validated in older adults. And so you really have to keep up with the literature and periodically look at it if you specialize in working with older adults. One such screening tool that it has been validated in older adults is the Michigan Alcoholism Screening Test. There are others out there, but there aren't a lot. So I think just taking tools that are designed mostly for younger adults and are tested in younger adult populations, it doesn't mean you can't use them, and it doesn't give you useful information, but I think you can't rely on it totally. And that's hopefully, as there's more interest in this topic and more research, we will have better tools. Alcohol withdrawal. One of the reasons that people focus on alcohol withdrawal so much is because it is truly life-threatening. Fortunately, withdrawal from most substances, although uncomfortable, is not life-threatening, whereas alcohol withdrawal can be life-threatening. Detox, there's multiple detox procedures. So, and then relapse, rehabilitation. So nursing interventions in general, education. If you are administering medications, making sure that there's good support for that and education around that, depending on the individual and the situation that they find themselves in, what's most appropriate. You want to look at, is this person appropriate for group therapy, and is there a group of older adults? Are they more appropriate for individual therapy or family therapy, or a self-help program? And 12-step programs are a very common self-help program, but there are others out there. So, and this is just an example. If you look at the middle of this slide, here's the list of the 3 medications that are used in the United States for alcohol use disorder. And you'll notice that they all do different things. So naltrexone decreases pleasure associated with intoxication. And there's some evidence that naltrexone is probably useful across multiple substance use disorders. You have to be careful. You can't use it when somebody is on a scheduled opiate for any reason, unless they're on a Suboxone or one of the combination treatments. But acamprosate eases withdrawal symptoms. Disulfiram, that is probably the oldest of the medications that we have, and it makes you sick if you drink alcohol. And so, if people take it every day, there's a small subset of people who really benefit from that type of approach. If I take this pill every day, I'll get violently sick if I drink alcohol, and this will stop me from drinking alcohol. For most people, that's not actually going to be a successful path to take, but there is about 5% of people who seem to, that really helps them. Prescription medications, medical personnel being part of the problem. That is recognized more and more, and geriatricians, and gerontologists, people who specialize in working with older adults, pay a lot of attention to this, and a lot of pharmacists have education around this. The number of medications a person is prescribed is directly related and correlated to the risk of misuse, inadvertent or purposeful. And sometimes inadvertent misuse can lead to purposeful misuse. Polypharmacy, by definition, is when people are using 5 or more medications daily. And so it's very important for people who are prescribing medications to older adults. It's very easy to get into this pathway of prescribing more and more medicines. And sometimes that can't be helped, right? That's just, if somebody has heart disease, if somebody has cancer, if somebody has serious mental illness, they may need multiple medications. But if they don't, you want to pay attention to it. And if the person does need multiple medications, you want to really evaluate before you prescribe and do good education. And so what medications are misused most commonly? Cardiovascular meds, benzodiazepines. That's the most common. Diuretics are actually frequently misused. Cathartics, so people looking to lose weight will often misuse cathartics. Sometimes they'll misuse diuretics, which can be quite dangerous for older adults. And antacids, thyroid meds, and anticoagulation meds can all be misused. And again, some of this is purposeful, some of it isn't. And you have to really take a look at this. Whenever you have someone who's on medications from one of these categories, you need to evaluate at every visit, or at least periodically, what meds they're on, and make sure that people are using their meds appropriately. And so when you're assessing somebody for prescription medication misuse, it's very similar to alcohol. You can use the MASG, substituting whatever medication a person might be misusing for the alcohol in that, using the same questions and scoring it the same way. There is some evidence for that. Pay attention to what your patients are telling you. If they frequently lose their prescription, my dog ate it, or the pills, or I threw it away by accident, you have to be very careful for that. And things to pay attention to are, in the United States anyway, there are databases. So in Oregon, as a physician here, I have to be a member of the statewide database. And before I prescribe certain substances, most notably opiates, I'm supposed to log into that system and check And the things that I'm looking for is this person getting multiple prescriptions for opiates, say, from multiple physicians? And have they, is there evidence that they're misusing it, that they're getting large supplies? You always want to look, is what people are, their chief complaint or what they're coming to you, does it match their clinical presentation? Are they complaining about terrible pain and yet there's no clear evidence of pain? That's a little tricky because chronic pain does present differently than acute pain, but you still want to look and really try and match that up. One of the key things is looking at above average knowledge about medications is often a little bit of a warning sign. When I was training, I was always taught you have to be really careful with nurses, physicians, and healthcare providers, because as a group, there is at least the myth that group of people are at higher risk. I'm not so sure that people who are actively working are at higher risk, but I think when you get into older adults, that there may be some truism to that. I haven't seen data though. And you always also want to look for signs or symptoms of withdrawal when you're looking for prescription medication misuse. You want to assess all medications. You want a safe detox plan if you have diagnosed somebody with substance use disorder. You want to educate somebody about what to expect. Depending on the medication, they might need seizure precautions or education, for instance, for benzodiazepines or alcohol, low stimuli environment. If they're going to, you expect them to develop symptoms from substance use withdrawal, you want to make sure that they have access to ways to treat that. And that can actually include other medications. Often it's very helpful if somebody is not living alone or if they have home health or some other person to help them. Nutritional support is very important. A lot of times people who are misusing substances are not eating properly. And so you can actually go a long way to helping people succeed by helping them get at good nutritional support. And then a multidisciplinary approach. So follow-up is essential. If they're in a formal treatment program, making sure that they're participating. What you're going to look for is, do they have decreased drug-seeking behavior? And you want to, include education for appropriate medication use and what are the effects of misuse. And so there's a lot of different ways to do that. And there's a lot of education. So the National Institute of Health, the National Institute of Mental Health, the National Institute on Aging all have information about various medications and use and misuse. And they can be, there's, in the United States, people can order all sorts of information. They can get DVDs and pamphlets and information mailed to them by the federal government. There's a lot of information out there. And so having somebody in your office or on your treatment team, matching up education resources to the person is key. For non-prescription medications, don't forget, you need to ask about it. And that includes, quote unquote, natural medicines or herbals. For the record, everything is made of atoms and molecules. So there really isn't anything that's unnatural. And there is sort of a subset of the population that somehow believes if something grows in nature, it's safer than something that comes out of a pharmaceutical laboratory and factory. They're both made out of atoms and molecules. And, opium is sort of a typical example. Opium is underlies all opiates and narcotics, but opium is clearly not safer than many of the other opiates. And so, I think there's some misunderstanding about that. You want to, when you have somebody who has a history of substance use disorders, either advertent and planned or inadvertent, you want to really stress the importance of consulting with the physician or primary care provider or the pharmacist before taking any medications, including non-prescription meds. And you want to evaluate people's understanding of the effects of medications, including non-prescription medications. A lot of times people don't understand that over-the-counter or non-prescription medications can be just as dangerous as prescriptions. And so these are just some tips for safe use of a medication and things to instruct people about when you're working with people. And what I find is helpful is to have kind of a little checklist and have somebody in my office whose job it is to really go over all of that every time somebody comes in for a visit. The last substance that I'm going to talk about here, and then we'll get to some questions, is nicotine. Tobacco use is a risk factor in most of the leading causes of death for older adults. Many of those who are 50 years old or older express a desire to quit. It is thought that only those with chronic illness tend to have the motivation to do so. I actually think there are a lot of people who would like to quit, usually smoking in my patients. And older adults who do stop tobacco use can increase their life expectancy, and even more can increase the quality of life going forward. And that is even somebody, for instance, who's diagnosed with lung cancer. What we know is if they quit smoking, they will be able to respond to treatment better, and they will have a better quality of life for what, as they go through the next steps in their life. One of the key things to know about nicotine, and I used to use this when I was a primary care provider at a veterans hospital. The more times you have tried to quit smoking, the more likely you are to be successful. So instead of it being multiple failures, you need to frame that as actually multiple successes. The more times you've tried to quit, the more likely you are to be successful. I'm here to help support you. This is important. You can do it. Many people have done it, but it's very hard. And I even go so far as to really talk about some of the neurophysiology of it. Nicotine goes right to the pleasure center of the brain and it hits it. And when you take your nicotine by smoking, it goes right to the brain very quickly. And that's why people continue to smoke. That's why that next cigarette is so important, because your brain is sitting there telling you, this is the best thing you've ever done for me. Do it again. And so it's very hard for any of us to believe that our brain would lie to us. But that's the kind of education that I provide to patients when I'm working with them. You have to get them at the right stage, though. If a person really thinks smoking is the only thing that helps me get through stress in my life, that person is not going to be able to work on quitting smoking until they have some other things that might help them get through stress. So you have to, which brings us back to one of the early stages. You really have to start with what is it that people need? What stage of change are they at? Where are they in that? And you want to fit your intervention into that stage. Nicotine assessment, there's nicotine withdrawal, and there are scales out there for it. You can look at their pattern. There's a nicotine tolerance quiz, and here's a link for it. There are medications for nicotine withdrawal, including clonidine, which is an antihypertensive. That's actually used in withdrawal from a number of different substances. You know, and here's an example of a behavior modification program, but these are the kind of very simple things that you can just learn a few of these and incorporate them into your daily teaching. And so this is called the postpone, inhale, reconsider. So every time you take a cigarette from the pack, I want you to look at it, put it back in the packet, in the pack of cigarettes, and then just wait 5 minutes. During that 5 minutes, you know, you might want to do this. Place 2 fingers in your mouth. Please clean your hands first. As if you were smoking, inhale slowly, repeat as necessary. Fascinatingly, just this intervention has reduced smoking by 50% in a number of people. And so finding a few of these, either learning them yourselves or having people in your practice or your on your treatment team, and working with people, matching up which program is going to help this person. But that's just an example. When you are working with somebody around tobacco, you want to look at assessing for decreased tobacco use. You want to positively reinforce that. When somebody has quit, you want to check in with them. You want to positively reinforce if they have quit, but if they've relapsed, which is a common part of substance use, then you want to help them see, you know, what might have led to that and how they can get back to a point of maintaining their abstinence. And you want to help them understand the effects of nicotine and tobacco on the body. Caffeine, similarly, you know, these are some of the symptoms that go along with caffeine. And caffeine intoxication can actually really mimic many cardiac diseases, in fact, and some neurological diseases. And I thought this was sort of interesting. This was kind of a comparison of how much caffeine is in each one of these products. And what you'll see is that drip brewed coffee, instant coffee, and tea were certainly the big offenders there. And there's things that you can substitute. You know, substituting hot cocoa is one way for people as they're trying to taper themselves off of caffeine. One of the interesting medical facts about caffeine is that withdrawal severity symptoms is unrelated to how much caffeine a person was taking in. And so people can have very severe caffeine withdrawal headaches, even if they weren't taking in huge quantities of caffeine. And so you want to help a person be prepared for that if this is their substance use of choice. So you want to look for signs of symptoms of intoxication and withdrawal. You want to encourage non-caffeinated products, educate on the effects of meds and caffeine. And again, your interventions and evaluation have to match the stage that a person is at. So in sum, late onset is different from early onset. A lot of times late onset, and I have to apologize for the typo on the slide, but congratulations if you saw it. Late onset, there's often no need for an in-depth formal substance use disorder treatment if the duration is less than 3 years. A lot of times, brief interventions can have great impact here. You want to consider 12 steps, cognitive behavioral therapy, mutual assistance from peers. There's good evidence that those 3 interventions are equally efficacious across the population, but that doesn't tell me which one is going to be best for you, right? So working with a person to match them to the treatment is important. There are some substance use disorders where medications have been shown to be helpful. The big 3, alcohol, opiates, and nicotine. Here are some resources. references. And then there are many different places to find really good, reliable research, but here's two. The SAMHSA, which has a whole section on substance use treatment for older adults. And because a lot of times, you know, if you put a link in, it can become outdated. So I just took a screenshot of this so that you can see. Then there's the Addiction Technology Transfer Center Network. There's also the National Institute on Drug Abuse and PrEP. They'll be renaming themselves at some point. So that is the end of my presentation as far as formally. And so let's see if we have some questions here. All right. So I'm going to go back up to the top and see. All right. Please type all questions for Dr. Nash in the Q&A box. What is your experience with Chantix for smoking cessation? My husband finally quit smoking cigarettes 6 months ago with Chantix, but it gave him terrible insomnia. So I would, yes, this brings up a couple good points. So nicotine is definitely one of the things that there are multiple different treatment options for it. But anytime you have a treatment that consists of another substance, you have to look at the risks and benefits. Chantix, and I'm blanking on its generic name right this second, but is a medication that actually has quite a few side effects. So anytime before you take a substance, you do want to look to see what are going to be the risks and benefits for it. Certain substances are kind of what we call stimulants. They kind of rev up your nervous system. So that's nicotine, caffeine, stimulants, amphetamines, cocaine. So a lot of times a treatment for those substance use disorders are also going to ramp up your central nervous system and can do things like cause insomnia. So you need careful education before you take another substance. Has cannabis use increased markedly with older adults with legalization? Great question. What we have evidence for is that the population that regularly uses cannabis has aged. So there are more older adults who use cannabis than previously, but these mostly are the older adults who used cannabis when they were middle-aged or young adults. So we don't have actually a lot of evidence that older adults have recent onset cannabis misuse. And I'm not sure that we have good evidence about cannabis use comparing before and after legalization. Cannabis use is legalized in some states in the United States. It's not legalized everywhere. And when you take you look at data and you're asking people if they've been using an illegal substance, you know, it's a little harder to know whether you can trust that data. So that's an unclear question. Have you seen struggles for older adults with legalization? Oh no, have you seen struggles for older adults that are veterans? You know, veterans in the United States are a group of people who, for a number of reasons, are at high risk of substance use disorders. They're at high risk of chronic pain, and they're at high risk, especially younger people who were in the service in the 40s, 50s, and 60s when nicotine was routinely handed out and very inexpensive. Veterans, you know, were put at more at risk, I think, in some ways. But yes, definitely, veterans are a group of people who suffer with notable substance use disorders, but they're also a group of people who have access Veterans Services and the VA have lots of experience in interventions and focus on substance use disorder treatment. And I certainly saw that when I was a primary care provider. Can you compare the risk of heart disease, cancer with cannabis use and nicotine? So what I can tell you is that people who used tobacco products are at much higher risk of both heart disease and cancer. I think our data for cannabis is much less good. And in the United States, and because of the federal government's, well, it is, there is evidence that the federal government looked at substance misuse in certain racial populations and made it harder to, made it more problematic to study those substances. So for instance, and federally this is still true, it is harder to study cannabis. It's not possible to use federal funds to study cannabis use, misuse, abuse in the United States. It's actually easier to study cocaine use and misuse than cannabis use. And that was a decision at a national level when it was noted that people of color were more likely to use cannabis. So it was sort of built into, it was hard baked into some things in the United States, sadly. I think there may be some shifting with that over time as cannabis use becomes legal in more places in the United States. Veterans.
Dr. Nash, this is Angela. Before you go forward, we have a question that I think got left off that list. I want to slip it in there while we still have time because La Trevia wrote this question in at 2:21. So she's obviously been waiting a while. And the question is, are there any SUD screeners appropriate for the older adult population? Now, I'm thinking that she's asking about colleagues who might carry specialization designation. And are you aware of any CADCs? And this is what we call them in the US. We've got international participants. So I will let you address the niche work performed by some of our colleagues and if there's anything out there specific to older adults. And
yes, so I don't actually have I don't have memorized all the specializations that everyone under every discipline may have. I know specifically for physicians, there are geriatric specialists and geriatric psychiatry specialists, and there's addiction specialists, but there is no particular specialization. However, there are lots of people who specialize in working with that population. I would say currently it is a small group. And I think I'm not sure about social work or other disciplines.
Okay, thanks. And to answer the other piece of that question, we will send out, I have a copy of the short MAST form for folks to take a look at, and we'll cover that question completely. Thank you.
Yes, so, and I think we're almost out of time. So I appreciate everybody's active participation, and I want to wish everybody happy holidays in the United States here. We're about to celebrate Thanksgiving. Appreciate everybody's attendance.
Yes, and thank you to Dr. Nash.